We're going to be starting in just a couple of minutes. We're trying to work a couple of technical difficulties out. By the way, it is not morning. Okay, I'm going to go ahead and call our task force meeting to order. What we were trying to work out is to have our sign language transmitted, and we were having difficulty working it out. Kay is not with us today, who was one of the reasons for our sign language interpreter, but we will have closed captioning. So if you would like closed captioning, please turn that on your own computer. You'll need to turn that on yourselves as an option. And then we will have closed captioning on the recording also. So again, I want to welcome everybody and thank you once again to all of our task force members and advisors who have spent so much time working through trying to get this report done and our findings. And there has been a lot of flurry over the last couple of weeks trying to get this together. And I appreciate, I know all of you got this task force draft, on Friday. And so I know that wasn't a lot of time to review it because it's fairly lengthy. I went all the way through it and did some editing myself and know how long it takes to read. But I hope most of you were able to go through it. And we'll get to that in a minute. But the first thing we need to do is roll call.
Hey, everybody. Just let me know you're here when you hear your name. Dr. Buttress is here. Representative Richard Bennett. Senator Hobb Brown. Senator Nicole Boyd.
Here.
Miss Miranda Carter.
Here.
I know Dr. Edney is going to be late, but Chris is with us today. Representative Kevin Felsher,
Here.
Dr. Tanya Fitz,
Here.
Dr. Heather Hanna,
Here.
Miss Biz Harris is with us. Sorry. Dr. Carlin Hennington,
Here.
Senator Chris Johnson, Miss Leslie Junkin,
Here.
Dr. Sophia Leggett, Senator Tyler McCon,
Here.
Representative Sam Mims is with us in person. Dr. Powell, I think she is here, but said she couldn't.
Here.
Okay, great. I saw your message in the chat. So, Representative John Reed, Dr. Courtney Walker, Mr. Keith Van Cannon.
Here.
And then I'll call out our advisors, Dr. Julie Parker,
Here.
Dr. Wolf,
Here.
Miss Penny Manzel,
Here.
Dr. Catherine Cassidy.
Here.
I know Dr. Carson can't be with us today. Dr. Candace Carter Stevens,
Here.
Dr. William Brown, Miss Sarah Myers,
Here.
and then we have Cody Smith from Medicaid with us. And we have a quorum.
So we have a quorum, so thank you again, everyone. So the first thing we need to do is to approve our minutes of October 16th. I hope everybody had an opportunity to review them, and I'd call for any corrections to the minutes or a motion to approve. Motion made. Second, okay. Thank you both. So minutes are approved. All right. So really the only task we have at hand today is to talk about the task force report draft. And we can do it one of two ways. I thought this is long, and we're happy to go through any part of it where you have a question or anything, but I thought probably, since I think that the portion that our legislators will probably pay the most attention to are the findings and recommendations, that we could go to page 22 under findings and recommendations and start with those. But what I'd like to hear from our task force, would you like to go through any other portion right now during this meeting?
Hey, Dr. Buttress, this is Dr. Fitz. Is there any way that we could put that, those pages that we're reviewing up into the Zoom? Like share our screen or?
Can you share screen? We will. That's a good question. It'd be nice if we could highlight each recommendation and finding.
I just say that because my file was corrupted and I didn't get to review it really. I'm sorry, Mary Claire, I didn't get to you this morning with that.
Did you hear that? She'll resend it. Did anyone else have any trouble with their file? No. Okay, good. I know. Dr. Fitz is one of the most tech savvy people I know, so I know it wasn't your fault, but we'll rescind that. Okay, we'll work on that. And they'll resend the file to you right now, Dr. Fitz. If everybody else, while we're working on that, can pull it up on their computers, that'd be great, or if you happen to print it out. Okay, so let's just start, like I said, on page 22, under findings and recommendations. The finding number 1, MSDH needs to conduct further research, and MSDH needs to create a plan to implement a different infrastructure and model for delivering early intervention services. And so that was one of the findings, like I said. And so they're outlined a lot of the backgrounds, everything that has been found to date. And then forward movement is outlined next. And then the recommended actions are on page 29 on that one point. And they're divided into 2, as you probably noted. Recommended actions for legislative recommendations is the legislature should consider adopting legislation to require the Mississippi Department of Health to conduct research and develop a plan, implementing a new service delivery model, including billing and reimbursement system, with a plan being due to the legislature on or before December 1st, 2024. So that would be a year from the time we submit our report. And again, this is to the legislature, extend the early intervention task force to serve in an advisory capacity to assist MSDH in implementing a new model, including adding representatives from the Mississippi Division of Medicaid and the Mississippi Department of Education, and also adding the executive director of the Center for the Mississippi Health Policy as consultant to the task force. So I'll stop there. Any comments on those? Does everybody feel good about those 2 legislative recommendations? Okay. Again, you have time if you would rather send comments, and over the next week, we're going to ask that you send any comments back to Mary Claire and Emily by the end of this week, by Friday. That gives us enough time, a couple of weeks, to go back through and try to address everything.
Susan, this is Heather.
Yes.
Hannah, I did have a question about this one. I kind of wondered about the length of time, a full year. Do we feel like, and it's rare for me to advocate for less time, but I just wondered if we do think it would take the full year, or if we think it's something that could be done in a shorter amount of time. Since we do have some of the research under our belt already.
We do. Take the time. The advice from the peer committee is we need to take the time, and if it's done earlier, that'd be great. But so we don't limit us more than we should. Never know what could happen, is the comment.
Okay.
I hear you, and I agree. A lot of the research has been done, and hopefully that will be of great assistance to MSDH.
Yeah. Well, and I think you always want to give it the amount of time it's really due, because if you rush it and you try to implement something that is not as fleshed out as it needs to be, we all know it's not going to stick. So
I do know that in the interim, the health department is planning on making some changes and has already implemented some of those. So, uh, Chris, do you want to comment on that?
Sure, I'm happy to. Some of the changes we are currently working on when it comes to referral process, and we even have some recommendations on how we could create some feedback loops that would be better for families and for people making referrals. We're going to go ahead and keep moving in terms of those recommendations because we heard those recommendations loud and clear in the report. But to have a full comprehensive report that really changes the systemic nature of the program, we'll have to work with the federal funder, and we want to make sure that we're looking at the financial implications also. So if we could keep it at a year, we'll certainly work towards a smaller timeline, but we know that it may also take that long.
Again, Heather, I will say, I am always one of those people to hurry up and fix, but I think we all understand the need to make sure this is a big issue, and that we want it addressed correctly. So, any other thoughts about that? So then the recommendations to MSDH. MSDH should plan to implement a new service delivery model by utilizing the expertise of the task force, OSEP staff, OSEP, and other technical assistance, including working with the Mississippi Early Learning Alliance to obtain a grant funding for possible technical assistance. And then finding number 2, MSDH needs to implement a new billing system to ensure service providers are reimbursed for services in a timely manner.
Dr. Buttress, I did have a couple of comments about that.
Okay,
In looking at the background description on page 26,
yes.
it references under the present system. Those are actual federal requirements, not system requirements that we've put in ourselves in terms of being the payer of last resort. So we might want to send some proposed wording changes for you guys to look at there if we could.
Can
then-
everybody hear Chris online?
I may not be-
Yes, okay.
Okay.
Yes,
Usually that's not a problem.
okay. Okay, so Chris is going to send some different wording on that. On the second paragraph under background information.
Correct. We just want to make sure that when we're talking about current billing systems, there are things that are outside of our control, such as private insurance, a lot of the Medicaid requirements that are there. And it kind of lumps everything together in terms of billing.
Sure,
So we want to put some distinctions in there if we can.
absolutely. Any further thoughts about that section or concerns?
I have a question. This is Sarah.
Yes, Sarah?
And Chris, you may have some insight, but I was just thinking through Hannah's thought about the timeline and all the research that has already gone into these recommendations of so many people. But I'm curious if this finding number 2 is what we're anticipating will take the bulk of the time, is really changing that billing structure system. And I think that ripples into lots of other changes and hopeful solutions for us, particularly when we talk about recruiting more providers to the system. But I'm just curious if that is true, if we think that this is the piece that would take the most time, or if it would just take a large enough, bank to support it.
I would say that generally this is the piece that takes the longest because this also takes not only a change in philosophy and practice, this takes like IT system changes also. And those tend to take a little bit longer than anything else. And Mary Claire, I don't know if y'all can look, Dr. Ennis said he was trying to make a comment and couldn't. I don't know if maybe he's on mute somehow. Okay.
And you do have some comments, Mary Claire, I don't know if y'all can see, Dr. Fitz and Leslie Junkin made comments.
Okay, we're going to get to those in just a minute. Now, what I didn't read, I read the finding, the recommendation. Let me just read that. The legislature should consider adopting legislation to A, require MSDH to conduct research and develop a plan for implementing a new billing and reimbursement system such as the pay and chase model, with the plan being due to the legislature on or before December 1, 2024. B, require the task force and peer staff to assist MSDH with the research and development of the billing and reimbursement plan. And C, ensure services provided in the natural environment are reimbursable. And then the MSDH recommendation. If MSDH selects to move forward with the pay and chase model, it should work with the Mississippi Division of Medicaid to determine the total amount of funding needed to establish a bank for reimbursing service providers on the front end. MSDH should include other possible billing and reimbursement systems in case the pay and chase model is not sustainable in Mississippi. Okay, now let's go on to comments if we can. Do we have it so Dr. Edney can make his? Dr. Edney? Not hearing him. While we're waiting for that, can we go ahead and go to some of the chat comments? If anybody wants, Mary Claire, will you read those for us?
If y'all could re-enter the questions that you had, since I logged in later, I cannot see what was there before I logged in. So if you could just copy and paste them so we can see, so I can see them. Emily's sharing her screen, so she couldn't see the comments.
Dr. Buttress, this is Leslie Junkin. My comment was more of a question. I know a lot of this is funding and pay sources for providers. One of the issues for many years as a contract employee with early intervention was actually just getting paid. Sometimes it would be 60 to 90 days, even longer, before I could get reimbursement as a contract employee. So it wasn't always about where the funds were, it was why the funds couldn't be paid to the person providing the services. And that was just me for just some clarification on this piece. Is it strictly about Medicaid reimbursement, or is this also addressing people who were getting paid through the Department of Health for services they were providing to families?
I think it's about really making sure all providers are paid on a timely basis. It was our biggest concern. But Leslie, so I want to make sure I'm clear. Now, for example, our speech, OT, PT, others bill the, first insurance companies, then Medicaid, and then the health department if they don't get paid from those. So are you saying that even contractual employees who were to be paid directly by MSDH were also having significantly delayed payments?
Yes, ma'am.
Okay. So do we need to add some different wording in there to make sure? Chris, I don't know if you have a thought or comment about that.
So I'm not sure when that was or if that was recent, but for our contract employees, we've gone to a different system that's automated now where they submit their time and then we submit their payment electronically. So I don't know when that was, Leslie, or if that's still an issue.
This would have been about 3 years ago, so probably prior to that system, but it was always a significant issue.
Yeah, we've implemented the new system within the last year.
Okay.
Okay,
Is
Great.
the new system pay mode?
No, that's for independent contractors. I think Leslie was speaking to contract employees.
Okay.
This is Nicole. I have consistently heard that though from providers within the last year. How long has that system been fully functioning and operational?
So the system for contract employees has been put in place in the last year. If we're talking about independent contractors, that may have been the case. I mean, I'm happy to look into it further. But we're
I think it would be wise that we include that in the recommendation because that is something I've heard as of a month ago, that it's still a systemic issue.
Okay. Chris said she was perfectly fine having that added too into the wording, so we can do that. We'll work on that.
I don't
This-
know if this is along the same lines potentially to Senator Boyd and Leslie's comment, but I think we added it later around enrolling or having access to the Mighty database, and I'm assuming that is the database that was recently put into place. Is that correct, Chris? You're referring to?
we're talking about two different things, I think.
Never mind.
This is Keith Buncannon, and I can address on the getting paid promptly. It is much, much improved as compared to 3 to 10 years ago. We would go 6 to 10 months, even my company, about getting paid. But now I think the longest it's been 6 weeks. So it is much improved with the new system.
Great, thank you, Keith.
If anyone would like to volunteer to change that wording to fit what you think it should say, we would appreciate it.
Yeah, I just want to make sure we understand
Right.
what we're supposed to change. And Dr. Fitz had a question on the chat. She said, should we make a recommendation that the legislature fund the development of the new system?
Okay. Did everybody hear, just 1 second, we have Dr. Fitz's comment about asking the legislature to fund the setup of the system. I'd love to hear from our legislators about what you think about that. Senator Boyd or
I'm
Congress-
happy. This is my only caveat in this is we have no idea of a cost or anything on this system. You're just asking them to fund basically a blank check right now. I would, so that is my question back to the group is, legislation is difficult to, if you want to put that this should be a system that's reimbursable at the health department, but a blank check is, I would suggest that we have some specifics before we ask the legislature to fund X, Y, or Z.
right? And I know,
Other legislators are on here and may feel differently, so please speak up.
any other comments on that? Yeah, I think that is where the health department in the recommendation is to look into that and to look into the cost because, you know, it looks like from everything, and I know Dr. Edney will want to comment on this, that there'll be an initial upfront cost, and then hopefully the system will be self-sustaining after that. That's the plan, right, Dr. Edney? Not yet. Hang on. Yes, I think so. Go ahead. Uh-oh. Huh.
Me? Hey, Dr. Edney, you got to mute your phone.
No.
Oh, mute your Zoom.
Yeah.
Now try it.
How about now?
Microphone.
I don't know what's wrong with the system. I apologize. I'm in Clarksville working on another one. I really get these issues. The issue of billing, y'all are looking at it wrong. And as a Medicaid provider for 32 years, who's billed Medicaid for 32 years, what the system that's in place by requirement, the provider has to bill insurance. Once it's denied, then pivot to Medicaid. If that's denied or not present, then they pivot to us. That requires us to vet fully. The purpose of Chase is not to make our billing better. We actually do a pretty good job with our billing. It is to fix the system that's flawed, that's requiring providers to wait too long. Now, you can put a legislative mandate, but the system right now is what it is. I can't make Medicaid pay faster or Blue Cross pay faster. But with Pay and Chase, I can pay immediately and take that problem out of the way, and then the health department bear the burden. And Secretary Boyd, we're not asking for a blank check. I've already been talking to Chairman Reed, and we're looking at potential numbers. And it's a one-time investment. And if you want to fix this problem, that's what it's going to take. The billing system at MSDH is actually pretty good. But that's not the issue here.
Right. I think, could y'all hear that? Yes, I see nods. Good. Go ahead.
Dr. Buttress, I think there's some confusion maybe in technology right now. My thing on a blank check is, guys, when we make recommendations that the legislature fund X, Y, and Z, and he says that he has numbers, they're numbers that are not in this report, and they're numbers that this committee doesn't have. And so my suggestion is that when this committee makes a recommendation, and I firmly stand behind that, and I've got legislators texting me that they do too, is we need to know what we're asking the legislature in the round in numbers to fund. And we have lots of people that come to us saying, you need to fund X, Y, Z, but they don't give us dollar figures or anything like that. And I've got lots of text messages right now that everybody's in a full agreement that if we're going to make a recommendation for funding, we need to know what those dollars look like. So Dr. Edney, if you have those, let's provide those to the committee. But if the committee is going to make a recommendation on that, they need to have those numbers. And I firmly stand behind that.
And I totally agree. And we're working towards that number, which we should have by session, that everybody in the task force would have a chance to evaluate the debt. We don't have the complete number now, but the issue is that what's the new model that we're shooting for? And then the legislature and its authority will decide to fund it or not. But if you put a mandate for us to reevaluate our billing and reimbursement, we'll do the best we can. But there's a lot of part of billing and reimbursement that's outside of our control.
I think we certainly understand that right now, the way things are set up, there's not, the billing process is in the hands of the providers right now, because they have to first do the billing to insurance, then to Medicaid, then to the health department. So you're right. It would be hard to, other than for the health department to be exceedingly quickly responsive when the bill finally comes to them, it would be hard to figure out how to improve that. I hear you. And I think others do too. I think the issue that our task force has felt is that's on the table and we need to do something about is this is too hard for a private contractor who's working for themselves to do and still give services to children, and their time would be better spent giving services. Dr. Edney, I know you agree with that 100%. And so
access to services. I don't know why any provider, other than just a passion to take care of these children, would go through the referral, go through the plan. And this is going to be a long process. Do things differently.
So I guess one of our questions, sort of on the table is, I know, Dr. Edney, you've been looking at some numbers and some cost, and we have two X's in our report on how much money that should be to help, because we don't know that number yet, like Senator Boyd pointed out. The question is, we know by the end of 2024, there would probably be a clear idea. I guess one question and concern that I personally have, and I know there are a couple of other task force members out there who also have that, is there perhaps a number that we could request from the legislature that would help jumpstart this, if this were a phase-in action or something like that? I know the original dollars we had talked about on the side were huge, and I know that your conversations with Congressman Reed were perhaps that this is awfully high number. And so we need to have really clear documentation of what exactly is needed on the outset. Would this be a phase-in for statewide? And again, that's why that December 1, 2024 date was put in there. Obviously, there's a great, well, not obviously, I believe, and I'd love to hear from the rest of the task force on that, this point, that I think everyone mostly on the task force believes more money needs to go into early intervention, no matter what. But we all had agreed that putting more money into the system right now, the way it is set up, is will not fix the issues.
Dr. Buttress, just a question for clarity. With the December 1st, 2024 plan as a recommendation, would you all envision that a pay and chase or a centralized billing model would be part of that plan? Or would you all envision that a pay and chase or centralized billing be demonstrated prior to that plan?
Yeah, we had written it in as that would be part of the plan that was made. If the health department wishes to run that pay and chase model on a trial basis to see how it works, obviously that would be great if there were a way to pilot it some way.
So I don't want to overshoot my skis, but maybe that is a smaller number that we could come up with for a demonstration and then incorporate it into the overall plan. Just a suggestion.
And we can write that in if that, I think if that would make more sense, then, because to Senator Boyd's point, we have to be very clear on what we ask our legislators for, in all fairness to them. And so if you could come up with a number that would allow us to say X dollars is needed to pilot this plan in X area, that would be really helpful. But we need it pretty quickly.
Right, I know, yesterday.
Another question?
I think it's more of like
Okay, go ahead. Yes, please.
Okay, this is from Dr. Cassidy. So she says, as I understand it, part of the delay to providers for MSDH payments is that MSDH pays through the state payment system as it does other contractors. So they have to create a magic portal account. She says, for example, she puts in all her charges for October in MIDI by October 31st. And then she says today MSDH sent her an invoice that she signed and approved. And then she says typically we'll get that payment by the end of November. So for services provided on October 1st, you're not paid until the end of November. That is significantly longer than insurance reimbursements, and that usually takes between 1 to 2 weeks from the date of service. But it's her understanding that this timeline for paying state contractors is not controlled by MSDH.
So I think that's reasonable that we pay through Magic and through pay mode, like someone asked earlier. And the standard turnaround time is about 45 days after the state's presented with an invoice. So that's probably the turnaround time she's speaking about.
Any other comments?
I've got a quick question, just because I'm learning a little bit this. When y'all are talking about a new system, are y'all gonna have to do a procurement for that, or can y'all just do the fix? Because if they're gonna do a procurement, I'm just gonna speak from our experience. 1 year is not idealistic if they're gonna have to procure a new system. But I'm just gonna put in my 2 cents on that one.
No, Cody, you're absolutely right. If we're talking about any type of procurement, I mean, it'll take a year for a procurement just about. The system that I was speaking of, we built a system in-house to help us with processing some payments. It's not a fancy system, but it's functional. Let's put it that way.
So are you saying that perhaps the year is not long enough, or you have a system in place that would work?
So I think we're talking about multiple things.
Yeah.
When she was asking about being paid as a contract employee, we've put a system in place in-house to help us be more efficient with those payments. If we're talking about procuring a system, whether it's an IT system, professional services, if we have to go through a procurement process where we have to advertise and get proposals and have that open, transparent process, that can easily take a year in and of itself if it's a large procurement.
And my thinking is the year is for the plan that health is going to develop. Now, it could take them longer to implement a new system. The year is specifically for the plan.
And I would imagine that plan would outline if there were to be any type of procurement that would be needed and what those timeframes would be for that procurement, or the anticipated timeframes, let me put it that way.
That's what I was thinking too, Chris, is that's what would be in the plan.
Okay, any other questions? I see something else coming up in the. Yes, Dr. Edney?
And I envision this process being us developing the plan, all of us doing it together, the task force with health. I'm not anticipating us trying to design something and then show it to y'all. We need to do it together to save time, I think.
Lots of heads are nodding yes in case you can't see us.
Right, yeah. Yeah, and that's one of our recommendations, is that the task force will be extended for another year to work alongside. We wouldn't, I hope nobody will drop off the task force because we need everyone, but if that is granted, it would be less frequent meetings, more like quarterly meetings to get together on the progress and all. Okay. Yeah, I think the other finding number 3 is, in order to ensure the program improvement, additional funding and resources are needed to support the First Steps program. And I think, like I said, everyone already knows that. We talked a lot about the current level of funding and then forward movement. And if you'll go to page 32 now, the recommendations to MSDH. Number one, MSDH should use ECTA's financial planning framework to project the amount of financial resources needed for the First Steps program and include the long-term financial benefits that program expansion would represent. MSDH should also include the sustainment of competitive provider rates in order to retain and recruit service providers, should provide this information to the legislature in its service delivery and billing reimbursement plan by December 1, 2024. And the recommendation to the legislature is utilizing financial projections and benefits provided by MSDH. The legislature should consider increasing the appropriation provided to MSDH to support the First Steps program. In the addition, the legislature should consider requiring MSDH to provide data and information to show continued program improvement.
Historically, I learned that 10 years ago, our state funding was about $7 billion.
Right.
Dr. Buttress.
Yes.
This is Representative Felsher. I am traveling and I don't have the report in front of me. I tried to read it and retain as much as I could. Could you expound upon, or someone expound upon, the funding of the program? If I recall, it said that they estimated about 12 or 13% of our newborns to age 3 population had a disability that would qualify them for the program, but we were only treating less than 2% of that. Is that correct?
Well, we're presently treating around 1.7%, 1.5%. And the speculation is that we probably should be treating at least twice that many. Now, when we talked about that, Representative Fulcher, you're correct. If you look at the number of children who would qualify in some states for developmental delay and qualify for First Step services, when you look at our poverty rates, our education rates, the rurality of the state, et cetera, then it does factor out that around 10 to 15% of children would likely need early intervention services. We don't have that hard data. But what we do know is that we are vastly underserving the population of birth to 3 children. We also know that the early intervention requirements for entry into services, where you have a 33% delay in one area, that was implemented, I think, probably somewhat for cost containment because of, I don't know exactly why, it was changed several years ago from a 25% delay to a 33% delay in one area, or a 25% delay in 2 or more areas. A 33% delay for a child less than 2 is a huge delay. And so it would take a significant delay for a child to qualify for services. And what our task force believes is that that is too strict of a guideline, and we are not intervening on services early enough that are easier to ameliorate than if we do it later. When you have pathways already laid down and set and habits set, especially in things like speech and language delay and motor skills. Those are issues that if you intervene early, you typically can overcome some of those milder delays. I don't know if I answered your question.
More or less, but in saying that, that brings me to my second final question, which is sort of national kind of standard data. In terms of that 33% versus 25%, and more specifically in terms of program costs versus the costs that are actually being remitted to the providers and whatnot, it seemed to me, if I'm remembering right, there was actually more admin costs to the Department of Health for running the program than it was actually paying out. Is that those two things, that 25% versus 33%, and program, is that a national norm for the program, the cost, as much as it's paying out to the providers, or is that abnormal?
So the issue is that there are some monies that are designated to go to administrative cost. The reason our numbers look so terrible is that right now, the vast majority of monies supporting our program are coming from the feds rather than from the state. Whereas in other states, in many other states with more robust services, the vast majority of services, money in the early intervention program are coming from the state rather than the feds. There is a fixed amount of money that comes to Mississippi. It's a formula, the number of children. And so that fixed amount comes from the feds. And until our population increases, more money won't come into the state. Chris has some comments.
No, I was just going to add that when you look at the national averages, the national average is about 3.8% of the children. So 13 would greatly exceed a national average. So even if we went from the 1.5% that we're at currently with an increase to the 3, that would be significant in terms of an increase in service for the state just to get to the national average. I think 13 is a far-reaching number there. So if we just focus on even getting to the 3.8, we'd be better served.
Chris, if we keep investing money into the First Steps program, will we continue? Will the money be more centered toward the patient providers and go directly to them, or will the numbers continually be about even on what it costs to run the program and what is reimbursed to providers for the patients?
So I think the answer is both in some senses. Of course, with some of these changes that the task force is recommending, there's going to be some increased administrative cost in terms of if we want to have our systems talk to each other, if we want to have basically a revenue cycle set up for early intervention specifically, that is some administrative costs that will increase as we move forward. Our goal is not to increase the bank, so to speak, at the health department in terms of administrative support. Our goal is to get the money to the services while knowing there's still going to be some admin costs there. Sir?
Representative Filser, to your point, that part of the reason that number to providers doesn't look like it should is I'm assuming that's what we're paying out as a provider of last resort. And that's not including what third-party payers paid out over the year. But the important thing is I think every investment that we make in this program has to be through the lens of increasing the number of children served and then improving our outcomes. And you know, we need to make sure whatever investment the state makes, it's a good return.
Well, I echo your sentiments on that. I'd like to see a good ROI on any future monies put into this program, ensuring that they come to favorable outcomes and to a more efficient system for our providers so that they're incentivized to practice and to provide their services in this state. I certainly echo that, Dr. Edney.
I totally agree, sir. And my goal for the agency is
So, thank you, Congressman. Those were some great points, and Dr. Edney too. And I think we all agree the goal would be to serve more children and not continue to build administrative costs beyond what is needed from an efficient standpoint. Okay, we have an addition here. Mary Claire.
So the 3.7 million that's in the report that says salaries for MSDH staff, that's not just their administrative costs, that's also their service coordinators. So I think that's really important, that that's not just, we didn't break it out by what they administrative versus service coordinators, that's total. So that's why it seems so similar to the 3.4 million to service providers. So maybe that'll help a little bit with that question.
Hey, Chris, I got a quick question. So First Steps, is that kind of y'all's case management services, or is that the
Yeah,
Is that the
it's included
program?
as targeted case management.
so on that, I know, and again, I know we have state laws on that with y'all's relationship with Medicaid. The case management services, I know our managed care companies provide some of this, and Senator Boyd brought up some good questions at the last meeting that got me really thinking.
Mm-hmm.
And we might need to tweak some of the state law on it, but I'm wondering if it, because it's my understanding the funding mechanism on this, y'all provide us the state match for that. And then we draw down federal dollars, money comes to
Right.
y'all. Since we are paying some of those managed cares, if we can shift some of those populations to managed care and have those corporations actually pay for it, that could free up the 25% of costs that could go to other expenses. I don't know if, I know you and Tracy have been talking, but
Yeah.
I don't know to what degree y'all been talking on that kind of stuff.
So I think it might be something to look at as a component. If you think about the way that we currently provide service coordination, it's more like a waiver program, like a CMS waiver program. From that respect, in terms of what the model looks like for service delivery.
Because I know I was looking at one of the managed care companies' programs. Now it was really targeting pregnant women plus newborns, and it was actually pretty impressive. So I mean, I don't know if that's something you and Tracy have been talking about, but I know I bugged Tracy on it after I started hearing a little bit more about that, because that would free up some of y'all's funding.
Yeah, it might be something to look at long-term. I think the models are a little bit different. But we may also have a segment of children and families that would thrive in that type of case management. Although I think these kids that we're talking about have I think they have greater need than some of the kids.
Do you remember the per member per month where that the model is? I'm blanking off.
I don't remember what it is off the top of my head.
I was trying to remember, but I haven't looked at it.
As numbers start running around and get
Oh,
jumbled
yeah.
up.
Any other comments or questions?
This is Dr. Fitz. I would also like to point out to whoever was just talking that not all of these patients are Medicaid patients. Okay, not all of these children are Medicaid children. That there are Blue Cross and self-pay people who don't have access to a Medicaid managed care. If you even consider what they do as managed care is not what we're talking about here, that these needs are greater, that they need more support than a phone call from a nurse, from an MCO. And we need to support the health department in providing the services to the people who don't have Medicaid as well as the people who do.
I would agree with Dr. Fitz, and that's why also I think we need to make sure that the money we're spending, we're doing it efficiently. That way we can preserve those state dollars for those who do not have an insurance program.
Right. I would agree with that, certainly. And I would like to add, there has been some concern that sometimes, and Cody, you can comment back on this, that though some of the managed care organizations say that they do case management, when we talk to parents and others in the field, it seems that the case management is truly from afar, perhaps a phone call, and a lot of times not the depth of what is needed for some of these children. I don't know if we have any comments from others. But the hope had been that case management could be done more on a regional basis rather than centralized.
And I'm glad you brought that up, Dr. Buttress. I think that is one thing that's a little bit confusing when I read the report. It makes it appear as all the case management is done out of Jackson, and it's not. That case management component is actually at the regional and district level. The only thing that is centralized from that respect is the referral process. So when the referrals come in, they do come into a central point in Jackson, but then they are pushed back out to the local service coordination units.
Feel free to add or change wording
Okay.
so that it reflects things as they are.
Happy to.
Yeah. Cody, it looked like you were going to make another comment.
I will say, and I can't really go into too much detail because we are in the active procurement. I'm hoping that once the division's allowed to move forward, if our procurement is upheld, I do know that we have strengthened a lot of our contractual provisions on the managed care companies to ensure that they are properly spending money and doing those services that they are required to do. So with that, I'm hoping we'll add more teeth to it to ensure that's happening. But if there are any issues with particular plans and any particular issues with current plans and their case management, I would personally love to hear about it so we can do a better job of strengthening those to ensure those members are getting the service they need.
Thank you. Any other comments or thoughts before we move to recommendation 4? At the bottom of 32, finding number 4 is MSDH and the Mississippi Division of Medicaid should work together to improve coordination in the process of billing and counting children receiving early intervention services. And so, you know, I'll just say this to me was one of those areas of difficulty, because if you look at Medicaid numbers, it looks like a lot more children are receiving services than if you look at our EI numbers. And a lot of that is because so many of our providers truly have lost faith in referring directly to early intervention. So it might be really telling for us to be able to see how many children birth to 3 are getting OT, speech, PT, and then to compare them to the numbers that we have in early intervention and see what the discrepancy is. Because once we restore faith in early intervention services, I think that things will drastically change. I really do. I don't know if anybody else has comments about that point. I'll go ahead and read recommendation number 1 to that point. MSDH should work with MDOM to ensure that any issues with early intervention service and billing codes are addressed and options are considered to improve billing and reimbursement. Some of these difficulties could be addressed by bundling service codes and/or forming an early intervention chapter within MDOM that would deal directly with the early intervention claims. And then recommendation 2 to MSDH, Department of Health and Department of Medicaid could enter into a data sharing agreement that would allow transparency regarding the number of children enrolled in the First Step program, the total number of children receiving early intervention services in the state, and the total cost of such services. So Cody, yes, I was going to ask you to address that recommendation number 1, if you would.
So a couple of questions I would have on that. One, those codes that y'all provided us for us to do that report on, just because you receive one of those services, that mean you qualify, like you meet the criteria for early intervention? Because if not, like from 0 to 3, having those codes, I got to admit, what would y'all classify the early intervention population? Is it just because they receive one of those services, or is there a particular need?
Yeah, and that is a really excellent point, because providers, speech therapists, I'd love to hear from some of our therapists on our task force, but basically what early intervention says a child qualifies for services is that for one single, like speech therapy alone, it would be a 33% delay. From a speech pathologist standpoint, a child doesn't have to have a 33% delay to qualify for services. A 25% delay would qualify them. So I don't know, could I get a comment from one of our therapists?
Dr. Buttress, this is Sarah.
Thank you.
So yeah, I think that's a good point. So the way I look at it is early intervention is that developmental time frame that we're looking at. So when we talk about bundling codes in any, for instance, in any speech therapy session I may have with a 2-year-old, I may be doing direct language intervention, I may be doing parent coaching, and I may be doing feeding and swallowing treatment, right? So there's several potentially different things that that are within my scope of practice under my discipline that I would be doing specific to that developmental age with that family and that child. But to speak to your point of qualifying for services and the percentage of delay, yes, I would look at, risk factors. So maybe, for instance, a baby might have a diagnosis of Down syndrome. And even though I'm not seeing super significant communication delays yet, I know that because of the motor impact and how fine motor speech work should be, that we're going to need to do some work ahead of time and put in some total communication support. So I would qualify the child because of the diagnosis, right? Or I would qualify the child for other reasons. So I'm not sure if I'm answering the question, but there's 2 different things I think that we're talking about. Qualifying for the program, which we can change because all states, as we've talked about, can revise those qualification standards and give more training to the providers out there doing assessments and standardization of that process, right? To make sure that when we get those referrals from the birthing hospitals, that we know that even though they may not meet that 33% delay, or we can revise that percentage, they could qualify for early intervention. But then we're also talking about what happens when I'm doing all these different interventions and I need to bill for those and get reimbursed. And someone else may answer better than that.
So I guess I'm wondering if a good measuring stick for this, instead of just using the procedural codes, would be using diagnosis codes. I don't know what particular diagnosis codes would apply in here. I'm sure you could do some kind of restriction from 0 to 3 on the age and then utilize a diagnosis code. Now, again, when it comes to reporting diagnosis codes, that's not always we've been trying to get more standardization on that, but there have always been issues, but I do wonder if that would provide more of a clearer picture. And I do hope our data folks didn't hear me suggest another data report.
They're like yours, they cringe whenever you speak.
Is Dr. Cassidy in? I know she's currently working within the billing structure. She may have better insight there to that suggestion.
Hey, Sarah, yes, I'm here. I was actually just sending y'all in the chat. There is a list on the MSCH website about qualifying diagnoses. So we already have that list. And then Dr. Buttress, I just found out this out a few weeks ago. It looks like they have changed the percentage of delay. It's now standard deviations instead of the percentages. But that's also on that link that I just put in the chat.
So I'm sorry, I'm not sure I understood. So the percentage of delay, it's changed from percentage of delay to standard deviation.
Looks like.
Okay. And so for our early intervention program, the qualification now is different, Chris?
I'd have to look back at that. I know there was talk of going towards so many standard deviations. I'll have to look back and see if we actually pulled that trigger or not. But I think one thing to consider also is if we're talking about changes in eligibility, we also need to think about how that would impact kids transitioning to Part B, and what that transition would look like while we're throwing things to think about on the table. Just one additional item.
But to his question regarding the Medicaid, looking at the best way to potentially bundle or I don't know the answer, and someone may have more insight there. But I know with diagnoses, there often are not diagnoses yet, at least in some of the little ones that we're working with. So we haven't quite we have maybe a developmental delay or something like that. So I don't know. I know that in other states, they do kind of just an early intervention bundle and everybody falls within that. Again, I know there's probably pros and cons to all of those. But I think that you could use both, Dr. Cassidy, right now, percentage of delay and the 1.25 standard deviation. So I think it's still similar.
Okay.
Yes, I don't think that, I'm sorry, I didn't make that clear. I don't think that changes the issue we're talking about, just the way that it's communicated on the website I was sending you guys. I would say to your point about I don't, just in my experience, I don't see it with these diagnoses. Like if you're on this list, then that's usually not the issue. It is what you're talking about, Sarah, when you have kids with developmental delay that aren't at that level to qualify, but that we would absolutely see as therapists in another setting, if that helps.
Yeah, this is Carlin. I think it's important to note a couple of things relative to this discussion. Not all assessments yield a standard score that then translates into a standard deviation that is used to evaluate young children. There are a number of more criterion reference tests that are often used to evaluate kids that present itself better to the percent delay. So that combination makes sense. And then second of all, relative to the comment about the transition from Part C to Part B, which occurs when a child is turning 3 years of age. Children who qualify for services under Part C sometimes don't qualify for services under Part B because there is a difference between what the what is required under Part B. And that often is a source of confusion in transition for parents when their child has been receiving services all along, and then the parent says, "What do you mean they don't qualify for any services when they go to school?" And that's important, and that's a little bit finer tuned art to determining eligibility under under Part B than Part C.
Right. Thank you for that, Dr. Hennington. That, yes, apparently if they receive services for Part B, it has to show whatever needs they have to interfere with their ability to be educated. So sometimes some physical therapy differences or something like that would not qualify.
Yes, exactly. That educational impact is a critical component, whereas developmental impact might be a better descriptor for Part C.
And I think that's a good point, Dr. Carlin, just to zoom out and look at it, because essentially what we're saying is we're all saying more babies should qualify for early intervention than are right now. And so the problem is, as a state, for some reason we've gotten that wrong, right? So we should be able to see them. It's a much easier process to qualify them under Part C. And so that we can remediate those things that need to be remediated before we get to Part B.
Right. And right now we are definitely the opposite. More children are in Part C than in Part B. That would be best case scenario. Okay, well, let's go on to finding number 5. And I think we've already discussed this somewhat. Mississippi's First Step program needs to improve the referral process to ensure children and families receive timely services as soon as possible, as well as increase the number of children served in the program. And so I'm going to go on to there's a lot that is documented in this, but go to page 38 and we'll go to the recommendations for the health department. The health department should make changes to its early intervention referral process, including but not limited to A, editing referral forms, B, promoting an online referral form and process, C, implementing training for physicians, nurse practitioners, service coordinators, child care professionals, and service providers to ensure all involved understand the referral process and the importance of enrolling eligible children into the program. D, implementing processes and procedures for communicating with physicians regarding children referred to the program. And E, eliminating the rescreening requirement. We may need to expand a little bit on that, I guess, but I think that was one of the complaints that we had heard, is that providers said that they had screened, felt like their child was eligible, and then they were going through another screening, not evaluation process, but then were told that they were ineligible. And so there was some concern about that. Any comments on that from our advisors or task force members?
Just one comment, Dr. Buttress. If we did have more information around that, that would be helpful. The only time that we're screening that I'm aware of, a formal screening, is when we do screen for kids who are going into CPS custody or that are in custody. Those do go through screening, but that's a separate component and agreement that we have with CPS specifically for that. But there's no other re-screening that I'm aware of. So if there is additional information, that would be great.
Mm. Mm. Yeah, will you turn your mic on just to let or you want me to, okay. Biz was just asking if it was the physicians who were screening and then sending a child to early intervention and being told they weren't qualifying for services. Does anybody have specific cases in there? I have heard that from providers, but obviously that is, as a developmental behavioral pediatrician, typically when they come to me, they definitely require services.
Right.
So does anyone have, Dr. Fitz, are you still with us? I know you're trying to practice too, but yeah.
I mean, I do, you know, that's, you know, some HIPAA, but that has happened probably the one that hits the hardest, right, is because there are insurance patients because Blue Cross will not cover speech therapy, whose parents ended up going to the university and getting therapy through the preschool language group because private speech, you know, just to pay for speech therapy is, you know, over $100 an hour. But through the preschool language group at the university, they could get it for $25, which is reasonable. And when it came time to rescreen him, because his parents had sought services outside, he was still 25% behind. He was not 33% behind. And he was only behind in that one area. And it's frustrating. I think that's one of the reasons that we've lost so many providers. We've lost their trust, right, in the system. The ones, you know, because I can always, like Dr. Buttress says, write a prescription for them to get speech therapy. And if they have Medicaid and they meet the requirements, it's not a big deal. And that's the process of going through EI is a barrier to care for to some people. And we want to eliminate that barrier if we can. Is that what you were asking for, Dr. Buttress?
Right. And maybe it has more to do with the 33 versus the 25 and the one standard versus 1.5 or 2 standard deviations.
And I think Dr. Buttress, to Dr. Fitz's point, it could also be, you know, what you shared earlier, in that there were no providers available within that discipline, unfortunately. So in that region, right, enrolled with First Steps. So potentially that could be part of the problem.
Correct. We have heard that too. Yeah. Okay. I know this has been long and tedious, but let's try to get through this before 3. Finding number 6, MSDH should work to improve the recruitment, development, retention of highly qualified personnel and service providers. And again, there's the background information and the forward movement thoughts. And then the recommendations or actions are on page 43. Department of Health, number 1, contingent upon the type of service delivery model, Department of Health will need to A, set minimum standards that all program personnel must meet. B, assist program partners in recruiting highly qualified service providers. C, expand efforts to recruit highly qualified personnel within the Department of Health operating the First Steps program. And D, improve training efforts internally and through program partners hiring or contracting with service providers. Um, and then number 2, we kind of have a blank there, Chris. We're asking you. A lot of issues have come up regarding recruitment already being addressed. And so, yeah.
Yeah, I think I can send you some additional language to go there. Just to advocate for our service coordinators for just a minute, they actually do go through a lot of standardized training already, that they're trained and spend a lot of time being trained specifically in evidence-based practices. And I don't think that's reflected. So I'll send y'all some language there about what that looks like. And then also some things that we're doing internally to create some career steps for them, so that when they complete those required trainings, there's some, what we used to call benchmarking that could happen within that system. So I'm happy to send that.
That would be helpful. Okay, number 3, the Department of Health should work with the incoming CSPD coordinator to implement a robust training program for First Step staff and providers based on a set of core skills and competencies. And I guess that goes with number 2. Number 4, Department of Health should conduct a national search for a highly qualified IDEA Part C coordinator to improve recruitment and training of highly qualified personnel, and in return, improve early intervention services. Number 5, Department of Health should clarify the program's position requirements, particularly for the special instructor, developmental therapist position, to ensure that all qualified candidates with appropriate degree are utilized. Number 6, Department of Health should utilize the competencies developed by SICC when hiring and training personnel for the First Steps program. Additionally, the department should develop competencies for early intervention services not currently incorporated in the program, including assessment for autism spectrum disorder, psychological services, mental health services, and family training. And number 7, MSD should improve database interfacing between the MIghty system and other medical software like Epic to improve communication between providers. Should also determine the methods to reduce the lengthy enrollment process for obtaining access to the MIghty system. Any comments on any of those?
I'll just add that it recently our enrollment of providers and needing to make changes within the MIghty database has gone much, much quicker. So there's definitely been some good movement, at least in our experience.
We can hear you.
That I think will move us well down the road. You know, one thing with the decentralized structure is it makes hiring higher quality people much easier. You know, right now I'm searching for about 10 high quality decision makers for the agency, and just within the state system it's extremely difficult. So actually the vacancy rate for EIP is significantly less than the agency rate as a whole. It's anything that we can do to help us recruit higher. It's extremely hard to hire if you go
Yeah, we can't hear everything. I'm sorry. We-
He basically said that he needs about 10 really executive level, higher order thinking people to operate within the agency. But by it being not being centralized, it makes things a little bit easy because you can find better people that you don't have to necessarily look just here in the Jackson area.
Right. Any other comments? No. Okay. Finding number 7, the Department of Health needs to identify ways to increase outreach, education, and community awareness for the early intervention program. And the recommendation is contingent upon the type of service delivery. No, sorry. Recommendation on 45. MSDH should increase communication with hospitals, medical professionals, and childcare centers through digital correspondent, in-person presentations, and/or published materials about the services offered through First Steps. MSDA should strengthen outreach to parents and the broader public through health fairs, informational brochures, and online resources. Could additionally explore the mechanisms implemented in other states to conduct community outreach for the program, the early intervention program. And then 3, the department should identify high-risk geographic locations and demographic categories to provide additional supports to increase access to enrollment for families who could benefit the most from early intervention services. So basically increasing outreach to inform.
Dr. Buttress, I am wondering if some of these functions, particularly the ones you just mentioned, but previously as well, some of those functions are functions that the state ICC engages in. And so it may be appropriate to reference MSDH should in collaboration with the state interagency coordinating council, strengthen outreach. That's number 2. Just does that make sense?
Yes, everybody's nodding on this table. Yes, it makes good sense. Thank you.
Yeah, because they're already in place. Some of these folks are in place, and that in fact is their function. To advise the agency in some of these areas.
Okay, great. Thank you for that. Anything else before I move on to 8? Okay, number 8. The Department of Health should ensure services are provided in the child's natural environment. And I think we all know that there are many reasons this has been a difficult area, and you can go through the background information on that, but the recommendation is that MSDH should recruit more service providers into the program, particularly those willing to serve the child in the natural environment. And 2, MSDH should expand access to telehealth services, which can be counted as providing services in the natural environment for several services.
Just a comment there, rather than expanding access, because that's going to turn into a whole nother issue, I'm afraid, with that language. If we could say that MSDH would allow for telehealth services to be incorporated as a natural environment.
Sounds like a good change. Okay, so MSDH would allow access or would would allow telehealth services to be counted as providing services in the natural environment.
Along with Sarah, I would agree with that statement, but I think we also need guidelines. That would inform which services are appropriate for natural environment. So that might be a third recommendation or a subpart of that should develop guidelines and allow access or something along those lines.
This is Keith, and I would like to add that telehealth is not the optimum setting for therapy because, like during the pandemic, it was very difficult to even offer some telehealth services. And I don't think we should promote that. But if I do think telehealth is better than not having therapy at all, but I don't think that should be a routine therapy that's set up for every child every time. It should be just strictly an exception where a child would not receive services, not a routine to be doing that as a therapist.
Yeah, so Keith, I would concur with that, and that's why I said develop guidelines. And amongst those guidelines may be when other services, when other modes of service provision are not available, might be part of those guidelines.
Yes.
I guess I also wonder though about, I think guidelines makes perfect sense. And I agree with that because I'm sure there are some services that it should not be provided telehealth wise. But I do think we also heard from families that transportation to and from meetings and provider. I'm blanking on the terms right now, but you understand what I'm saying, that transportation was a hindrance for some families.
Right.
And so I do think that maybe not, saying that telehealth is preferred, but I think when it is appropriate could be a real boon to increasing access to services for families.
And certainly for some of the services, so as Keith mentioned, I mean, physical therapy, difficult to implement via telehealth, occupational therapy, somewhat difficult, speech therapy, maybe a little bit easier, but then other case management services and behavioral management services such as that are great with telehealth. So I do think the idea of guidelines is a good idea. And certainly to your point now, because we're supposed to be serving the patient in the natural environment rather than making them be transported, it is parents' choice though. So if a parent says, no, I want to come to the clinic, I don't want to be served in my home, for whatever reason, various reasons, that's their choice too. So, right, Chris, do we document that very well? Do you know that?
Yeah, I think I have seen that documented. How well may be another issue, but I have seen that documented when it's been the family's choice.
And Randy Carter added on the chat that she just suggests that the child and family needs be considered in considering teletherapy.
Yeah.
Yeah, I can expand on that in our personal experience, there have been times when my son we've had, intentions of leaving the home in order to receive therapy, but his nervous system has kept us from being able to do that. And in that time, it would be, nice to have that option and for providers not to be penalized or not be able to provide therapy because the plan, doesn't allow for it. So that we can meet the child's and the family's needs.
Right. We'll add that wording. That's great. Thank you for that. Okay, we're down to the last, number 9. The Department of Health should consider expanding the program's eligibility criteria by reducing the percentage of delay necessary to qualify for services and by adding an eligibility criteria for at-risk children. Background information to go through, and then the general, let's see, recommendations are on page 50. The Department of Health should consider expanding the First Steps eligibility criteria to allow children with a 25% delay in one or more developmental domains to be eligible for services. The Department of Health should consider expanding the First Steps eligibility criteria to include at-risk children based on an established list of biological and environmental risk factors or occurrences that could have negative implications for health in order to serve more children in need of early intervention services. And then increase collaboration between the First Step program and the Department of Child Protective Services to ensure the children in need with developmental therapy are referred to the early intervention program and receive needed services. Any comments or questions, additions, word changing?
Yeah, I think it's important. Number 2, at-risk children are already, as Sarah Myers indicated, they're already considered for eligibility, and she used the situation of a child with Down syndrome who may not already yet be experiencing delays in areas, but we know based upon that diagnosis they will at some point in time, or the delays are not significant enough yet, but we know with time they will. And so number 2 may be redundant with what's already there. The environmental factors are not.
Yeah, one thing, Dr. Hennington, that we did receive were some complaints from parents with children with Down syndrome who were not ruled eligible. We have more than one instance of that. That may have been in error by the provider who was out in the field and not secondary to the rules of early intervention, but we've heard several struggles in that area.
And I'll just quickly add what we meant by the term at risk is the category that the federal IDEA statute includes as at risk. So according to federal reports, only about 6 states actually say that they use the at risk eligibility category. So you're absolutely right that there are automatic qualifying conditions, but we're talking about this extra at risk category that could potentially be added.
Sure, such as exposure to lead.
I don't know the specifics, but that may very well be one of those.
Yeah, that would.
I hate to be Debbie Downer. I think we should consider the eligibility and the financial impact.
Right. If we expand eligibility, then we increase the cost of the program, no doubt.
But then the idea of having the program to begin with is to mitigate some of the need for later interventions. That's the goal, the hope of early intervention is that the costs, later on that are imposed are lessened by early intervention, and there's study after study to support that, which is why we have support for Part C to begin with.
Well said.
So Dr. Buttress, this is Julie Parker. I would also add too for that at-risk category, we have children born preterm, significantly preterm children usually get that ruling for early intervention, but you talk to many of the neonatologists, they have significant concerns also about children who were born much closer to their term date. And so many children, in fact, I visited with a mother just last week whose baby was born significantly preterm, and they did not get referred to early intervention upon discharge from their NICU stay. So I do think there's that population out there as well too that fits into this at-risk category from the federal lens that has to be considered also in our state.
Yeah, I think what comes to mind for me would be a child who's born with significant hypotonia, low tone, or hypertonia spasticity. And a child in that first 6 months of life is not going to qualify for a delay because the motor, the expectations, even though we know that child by the time they hit 8, 9, 10 months, will eventually qualify. They won't qualify, but they're at high risk for motor problems. So that could be perhaps remediated because of everything we know about plasticity in that young period. So again, yes, I think it would likely increase cost, but the benefit later on could be pretty extreme.
Yes, I very strongly agree. Was about to ask about that population. So Dr. Barker, Dr. Buttress, if there is the ability to add that recommendation, thinking about children discharged from the NICU or at a certain level of preterm, I think that we could really smooth the barrier, smooth the path.
They're taking copious notes over here. Okay, well, we made it through all but the final recommendation, and that is the legislature should consider passing a bill to require the Department of Health to submit dates to the legislature and peer regarding implementation and recommendations in this report, and the early intervention program be reviewed in 3 to 5 years. And I believe that is it. Any questions?
Yes, I have. This is Keith. I have one more question. I noticed in part of our documentation that it had mentioned proposing a raise in providers' income. We just received a raise, and which brought us pretty neck and neck with Medicaid reimbursement. And I don't think it would be the appropriate time to ask for a provider increase in rates. I think we should concentrate on serving the children because I think our pay is adequate at this time.
Chris just said she did not pay Keith to say that, but I think the main issue is to make sure that raise could be maintained, right? The legislature had granted additional monies to allow that raise to happen. And so I hear what you're saying, Keith, the raise was something that was satisfying to most providers, but that we need to make sure that raise is maintained. So maybe if we can fix that wording. Okay, so next steps, let's talk about that just for a minute. We'll go through the revisions. I'm looking at Mary Claire because she is helping lead the charge on getting this report out in a timely fashion.
I would just ask everyone to, and I think I put this in the email, but if you could just send us your, like a point sheet, like this is the page number and this is what I think it should be. If you could send that to us by Friday, I think that would be helpful, so that we can get the changes in, we can get it to our editor and then get it back to all of you, because we will need to meet again in November to approve the report.
Okay, so they took notes, but if you want to make sure your comments got included, please go ahead and send that in, because we want to make sure that we get it right. And what we'll try to do is send it out again toward the end, the middle of
I'm
the,
thinking sometime next week, but it depends on how long it will take our editor to
okay.
go through.
So if we could get it to all of us that week, and then the following week is Thanksgiving week, and then we have 1 week at the end of the month before December 1st, before it's due. So would it be appropriate for us to meet that last week in November?
I think that would be fine. I think that's plenty enough
Is that
time.
okay? The last week in November. And it seems like, is Monday a good day for everybody still? Please speak up, guys, who are online.
Yes.
So,
Yes, that works.
okay. That would be, sorry, I'm trying to look the date up. That would be the 27th of November.
Yes, the 27th.
Okay, well, we'll have another meeting, the 27th of November. It may be shorter, actually. But we just want to make sure that once you get the report out and look at the final-ish product, that you can put your stamp of approval on it. So we'd really appreciate you all being here that next Monday I guess we'll do it at the same time at 1 o'clock.
I think also, if there's something that you feel is missing from the report that we didn't talk about today, we didn't get to, please send that to me as well. And what you think it should say, that would be helpful. Because if we have to do a whole lot of extra research, that's kind of hard on us. So if you could let us know what it should say, that would be helpful.
Okay. So once again, thank you, Emily and Mary Claire and Ted. I know you've had a big hand in this too, and everyone for your time and energy and all. And we will get this report to you in the next week or so, week and a half. Yeah. And then if you will please make sure you attend the Monday after Thanksgiving, so that we can have a quorum and get it approved and be done. We would all be very happy. So I want to thank you all, and I hope you have a wonderful Thanksgiving holiday. And I would like to entertain a motion to adjourn.
Dr. Betras, this is Nicole. I will make the motion to adjourn, but before preface that with, I want to thank you, the staff at Peer, whoever all has been working on this draft report. This is a phenomenal report. They've done a great job really capturing some of the information and the volume of material that we've kind of gone through. So y'all have done an excellent job, and I'm so appreciative of this work. Thank you. So on that, I will motion to adjourn.
Thank you. Sarah, second. Okay, Biz seconded. So the meeting's adjourned. Thank you.